How about another round of applause for our panelists here? All right, so we actually are doing pretty good on time. Thanks for the double time, Chad there. So we actually have two microphones set up on stands here, one right there and one right there. If anyone wants to queue up and ask questions, we got some time. Keep in mind that tomorrow's sessions, the breakout sessions, are really where the rubber meets the road to learn about the true details and ask the questions of specifics on how you manage your practice. How do you get lab contracts? How do you negotiate these things? So not the point for today. Today's the motivational, the understanding of the whys and the how, and you know why we're all here and how this all works. But we're going to go ahead and open it up to a few questions. So right here at the microphone.
Hi, I'm Molly Rutherford. I've been doing direct primary care for 3 years. Tell me if this is not an appropriate question for now, but I just wanted the panel to address Medicaid. If any of you are seeing Medicaid patients, how are you doing it?
Are we on now? Yeah, okay. Yeah, actually, we had an article written about us because of that. I see more patients now as a DPC doc than I Medicaid patients than I saw as an insurance-based doctor. The Medicaid system, at least in the state of Michigan, is so incredibly stressed that there are few doctors who accept it. So even the people who tend to be struggling and get Medicaid are usually, we have a lot of them who are willing to pay us on top of that to actually see a doctor. And in our state, at least, we're allowed to still order things under Medicaid. So if that functions as the insurance, and we get, so they'll still honor our orders, at least in Michigan.
Yep, and I'll riff off that. So I'm in Southwest
Kentucky says that's
Detroit.
illegal, so how are you able to do that?
I'm sorry?
Kentucky says that's illegal.
Illegal. She's saying it's illegal.
Yeah.
It's a state-by-state issue.
I'll riff off that.
Okay.
Just we're in Southwest Detroit, and we have a lot of low-income folks. Detroit is greater than 50% Medicaid, and so many of our patients have Medicaid insurance. They just want the care and the demonstration of care and the time with the doctor, a clean environment, and the ability to ask questions and be understood.
Okay.
And people are willing to pay over and above that out of pocket to see us.
No, I'm not a panelist, but I would say here in Florida we have what's called share of cost Medicaid, which basically if somebody has no insurance and you end up in the hospital, God forbid, with a major heart attack, you're in the hospital for a week, you run up a $200,000 hospital bill. Medicaid becomes retroactive to the day you walked in the door of that hospital, and it's like a $500 to $600 per month deductible after that. So it covers the hospital bill, and then after that the patient has Medicaid, which they can take forward with them. But the problem is they can't manage their chronic medical care with a $500 or $600 per month deductible. So those patients seek us out, and so we have many patients with these high deductible Medicaid plans that manage their chronic care through our programs.
I'll talk
I'm
to
going
you
to move
later,
to another
Chad. I'll
microphone
get it.
right over here.
I'll talk to you later, if you don't mind.
I would just mention, too, as a specialist that in Florida, I'm seeing the Medicaid patients will come in and pay what I call my fair cash pricing. I don't do a membership model. They can't get care for their chronic disease. And so showing up in the ER every few months for flare-ups of lupus or rheumatoid arthritis is not a really good way to get care. So they're very motivated to pay if the prices are kept fair.
Yeah, and I was going to kind of expand on that because that's a major savings point too. By having access through DPC, you actually decrease significantly ER utilization, and I was so scared of Lee beating me for running over that I kind of sloughed past that point. But yeah, I mean, that's another cost savings we get. It's funny with Medicaid, they thought ER utilization would go down when Medicaid was expanded, but since a lot of them couldn't find primary care doctors and they didn't have a cost associated with going to the ER, it actually dramatically drove up ER utilization and actually is burning out the ER docs.
Next question over here at this microphone.
Yes, Belen Amat from Grand Rapids, Michigan. Where do you guys see direct primary care in 10 years?
Well, as the smartest Michigan doctor, I think you can probably answer that.
You're talking to Paul? Yeah, I know what you were saying.
Anyone? Any panelists care to address that one?
Yeah, I think direct care is only going to continue to expand. Now it was a small movement of single-digit doctors that has grown slowly each year, but now that momentum is getting to that point of possibly linear, if not exponential. Like Dr. Lee said on the radio earlier this week, just with the attendees here, if everybody started to practice, that'd be a 30% increase in the movement. And if we did that every year, we have 250,000 primary care plus docs, and 1,000 are doing direct care. But now conferences like this are held several times a year with great attendance. Because the system is so broken, they're looking for it. Patients are actively seeking it out. Again, Dr. Lee can attest to when we're on the radio, it almost breaks the website. The amount of patients who call from across the country, very interested, sometimes desperate for this care, telling us their stories about their medication or troubles getting access.
Josh, would you mind addressing the question we get a lot about, why isn't this worsening a primary care shortage? How does this affect the physician labor, and why aren't we creating a mass shortage in access to primary care? Can you address that, please?
Absolutely. I think it's a false assumption we make. They say we'll have a physician shortage of between 50 and 130,000 doctors by 2025. But then the American Academy of Family Physicians has the most conservative study to say that 22% of our time is spent on non-clinical work, paperwork, EMR, et cetera. And they said if you take that 22% alone and multiply it across the workforce, that's the equivalent of 165,000 physicians, full-time equivalents, back in the workforce. So we don't have a doctor shortage. We have an efficiency issue. And we're burning doctors out by spending 1 to 2 hours on extra work for every hour of clinical work. When in reality, in the direct care model, 95% of my day is on patient care. It's the way it should be. So if every doctor did this, roughly 300 million Americans, roughly 500,000 providers who could, under a DPC umbrella, that's 600 patients per doc. So even if it was half that, that's 1,000 patients per doc. We have plenty of doctors. We just have to let them focus on what matters, which is patient care.
And another thing that's always ignored when making that argument is forgetting that that shortage, that theoretical shortage existed before we ever came into existence. So there's an ignoring the whole system that actually set up the shortage in the first place. This is a response to the stresses that created the shortage.
Question over here at this microphone.
I'm Janice Hudson. I'm from Florida also. I will say that I just started my DPC practice, but so many of my patients are actually Medicaid patients who can get free or very low-cost care if they can find anybody to accept Medicaid, but nobody's accepting Medicaid. And so they're willing to pay the fee. And I also want to address Dr. Rutherford's question, which is if it's illegal in Kentucky to see Medicaid patients outside the Medicaid system, and there are other states that that's similarly true, how you're going to fix that is bug your politicians. Go to your state legislature, demand patients have a choice.
Thank you. Microphone over here.
Chad, we know so many of us humans make decisions out of fear. Fear is a great driver for decisions. For the gentleman in your example, who you explain the financial benefits of a DPC practice, and he says to you, yeah, but what happened? I get hit by a bus, and I got to go to a surgery and hospital stay for 2 weeks, and I'm, as Lee said, I run up $200,000. That's why I keep my insurance. What do you say to that guy?
Well, that's a catastrophe. You get hit by a bus, that's a catastrophe. That's why you have catastrophic insurance. None of us are suggesting that people go bare, because as a primary care doc, I can't take out an appendix. Thankfully, as I understand the statistics, 95% of people in any given year will not utilize a $5,000 deductible in total. That means essentially only 1 out of 20 years are you using a high deductible health plan. Don't pay like you're incredibly ill every single year when you're only essentially utilizing it 1 in 20. Saves so much money. If you think about that case where he saves $18,000, I was talking to a guy who's type 1 diabetic on the way down, and we were talking about this very issue on the plane, and he does insulin, and he's like, my gosh, I'd have to pay for my insulin out of my pocket, and it's, $400 a month. And I said, okay, so that's about $5,000, so you're only $13,000 better off now. If you paid that out of your pocket. So and my wife did the same thing. We're part of Samaritan Health Ministries, my own family, and we saved $13,000 the first year. It's actually more than that now. The difference between my old policy and my health share is bigger than that now. And my wife, who's bright, she understands these concepts. She goes, yeah, but we'll have to pay for our physicals ourselves. And I said, okay, there's 4 of us. If they're $250 a pop, that's $1,000 between the 4 of us. Okay, we're not $13,000 better off, we're only 12. So it's just realizing the insane magnitude of waste by getting those more expensive plans. Still have coverage. Bad things do happen. You do want to insure against the rare event. You don't want to pay for the rare event every year.
And just dovetailing on that, that very far right column that Chad showed in his slide, that very short one, those short-term medical plans, the smallest of the small expense, right now those are being expanded around the country, but there's so much pushback against them, and they're being called junk insurance. And I would actually say that those are actually true insurance. It's probably the only true insurance that is out there right now. So we just kind of got to watch the language that's being used to describe some of these plans. And when we talk about the risk, the financial risk, and I'm not saying we shouldn't have insurance. I love insurance. I love my homeowner's insurance. I hope I never need it.
Cliff Tinsley from Virginia. I'm going to open up in about 3 months, and Emily O'Rourke just opened up. Thank you. I saw the numbers that Chad threw up there, and I'm sure the insurance companies see them as well. So I saw a post that concerned me recently, that insurance companies told a patient that they couldn't have their insurance and see us as well. Did you guys see that, or do you have any comments on that?
Well, like the HMOs mainly, first of all, they legally can't force someone to do that. But if they, as I understand it, I'm not Phil Eskew, so ask any legal, I should clarify, any formal legal advice should go through an attorney. But as I understand it, they can't legally restrict what you do. They can say we won't pay for anything you order if they're an HMO. That is a legitimate issue. Actually, I would really like it if insurance companies, if you are a board certified or whatever, maybe not, but if you're a licensed doctor in your state to practice medicine, I don't think how you're paid should make a difference. I think they maybe still should have an ability to say, oh, you're ordering an MRI every other day on a finger for no reason. We have the ability to say no to that. But they shouldn't be able to say no to you on the sole grounds that they're not paying you, and thus through the payment mechanism controlling you. It's either valid or it's invalid. And I think any licensed doctor in the state should have at least access to an authorization process. But yeah, mainly HMOs are the ones we get kicked back on that kind of stuff.
Ellen, can I toss that question to you? Because as a rheumatologist, you use a lot of rather expensive infusion medications, you order a lot of MRIs. Have you seen any kickback from insurance companies in terms of covering these things, or how do you do that with your practice versus things that are done in the hospitals?
So now I'm opted out of Medicare. I'm at the end of my 3rd year, and for rheumatologists, it's kind of a big deal. I mean, I may be the only one that I know of. Actually, there are 24 in the country. I looked that up not too long ago. So in the Medicare population, we thankfully have the ability to continue to order tests, and I haven't seen any pushback where they can't have it done in my office, so they have to go to the hospital, and so that has just been an inconvenience and an expense for them, unfortunately, because before I opted out, I was doing much of that stuff in my office. So I have patients who are now going to the hospital, and they bring to me these incredibly large bills, and they say, well, when I was getting it here, even though they're expensive medicines, there wasn't a big upcharge and a facility fee and everything. So it is an education kind of for the patient. At the moment, I actually am still taking commercial insurance, but I am trying to get out of, starting this coming year, to back off of that and become out of network. So there may be more to come on that.
So, but the irony is by having to send your Medicare patients to the hospital for an infusion that you could have done in your office, they're probably paying 10 times the price for that, or Medicare is paying 10 times the price for that.
There's no question about it.
Okay.
So they cannot threaten to drop their insurance if they come see us?
I'm not sure I understand the question.
Well, that's kind of what the post implied, that the insurance was going to drop their insurance if they saw a DPC doc.
I don't think, I'm not going to answer that question, but thanks for the question. Over here.
Yeah, I'm Shennery Cotter. I'm the physician that Hal mentioned in the introduction. And a year ago, I came to this conference having figured out how to make a go without our income for my family because I was ready to quit medicine. So going back to the physician shortage, the primary care physician shortage, I sat through this conference. I cried through Dr. Gunther's talk. I cried for poor Dr. Farago as he signed my book. And sorry. And now I'm practicing medicine in direct primary care, and I'm really happy.
Thank you. Good night. Yes, over here.
Yes, my name is Robert Berry. I'm from Tennessee, and I've had direct payments since 2001, but it's fee-for-service, looking to switch. And I'm also a member of Samaritans, has been for the last decade. I have a question, Chad. Have you, or has any of the policy wonks, figured out how much it would save the economy? Because I've estimated this,
Well,
and
actually,
I come up with about $1 trillion would be added to the, probably more than that, would be added to the economy if there was no insurance payment for primary care.
I think you're spot on, actually, because I did an article in Investors Business Daily comparing what we spend in healthcare to gross domestic products of entire nations. And essentially, we spend as the equivalent in medical care alone in the United States, equivalent to the 4th largest economy, the entire nation of Germany's entire economic output, the biggest economy in Europe, we spend in healthcare alone in the United States. And if you were, and actually almost half of that is based in government payment systems, Medicare, Medicaid, it's about 1.5 trillion. We are terrified of Iran and their ability to get the nuclear weapon. Imagine if CMS gets nuclear aspirations.
But I'm just talking about savings from primary care if you eliminated insurance.
Well, I don't know about the elimination of
primary
insurance.
care alone. If that were looked at from
I would say
the policy
elimination of
people.
insurance for things you don't need to insure.
Yeah.
You know, things that are smaller expenses that should be you able to plan for. An annual physical, if you know you're going to go see your doctor every single year for a physical, do not insure that. All you're doing is adding middlemen stipulations and cost. That's something that is baked into your premium, no doubt. So that's in theory something you could save in premium. And a lot of people, I talked about it being covered up in a morass of payment mechanisms. So many people have it buried in deferred wages. They say, oh, my employer covers this. Your employer didn't cover that. They could easily have given you more wages, but they chose to give it to you as a health care benefit because there's a tax advantage to do that, and that needs to be addressed. We could actually eliminate the employer-based health care system immediately by allowing HSAs to be used for insurance premiums because you immediately eliminate the tax advantage.
We're going to take another. Thank you for the question. Thank you for the question. We're going to take it from another microphone. Thank you.
Thank you for all the great speeches. I really enjoyed them. My name's Thompson Foy. I'm a medical student, and thank you. And I had a million questions, but I tried to narrow it down to some context and a question. So, my granddad was a radiologist, and he started practicing shortly before Medicare became a thing. I guess it was 64, 65, sometime around then. And I know he was my granddad, but he seemed like he knew everything about every specialty. And quick story about him, I believe it was his intern year. One day he decided he wanted to learn about the anatomy of the hand. So he went down to the morgue or cadaver lab, whatever it was, and he cut a hand off and he took it home with him. And he told me, he said, Thompson, I knew the hand. But I guess I'm saying that because now I'm on the wards. And I've gotten, I don't want to say in trouble, but just gotten that disappointed look because I take a little too long pre-rounding. I guess I like to talk to people. And it just seems like so much time is spent coding and all the stuff that I'm sure you're more aware of than I am. So my question is, how do you think direct primary care and direct pay services generally can affect medical education, even from the frame of mind of, say, changing, disrupting, innovating the training process, even like a apprentice-like training system? I think these are kind of big questions we need to be asking.
Well, Dr.
Paul,
Eck
would you
actually
care?
sees medical students. Dr. Eck is here, and I know she has medical students. We were just talking about that yesterday, and maybe you may want to approach her later, but it sounds like she does a wonderful job, and the only kickback, as I understood from her, is that the medical schools don't like her telling the students about all these options.
Do you do work with medical students in Detroit?
Yeah, so part of my practice, I do have a contract. I'm a clinical assistant professor at Wayne State, and I have a contract with them to host some of their medical students. And I also have a contract with the PA school. And it's really amazing talking with these students and just having the perspective of knowing what the medications cost and what the imaging services cost, and just trying to fuel them to be more inquisitive about, when you're rotating with a physician, how much do you charge for this, or what are the charges you send out? How much are you reimbursed for this, to help them understand the context of the cost of medical care. And also, just speaking at the medical school, I know that students really get turned down and amped up about direct primary care and wanting to understand how to deliver medical care on their own terms without these limitations. So I guess the challenge would be for the people in the room, which medical school is nearest to you, or PA school, or which NP school, or which residency program is near to you, and how can you get into those walls and tell the story of direct primary care and inspire the next generation of people.
One of the hardest things for students to understand is that direct payment mechanisms are not lacking compassion. Because most people say, well, if you want to do that way you're clearly not empathetic, you don't want to care for poor people and stuff, and that's not, this is a debate about what is the most efficient way to run a healthcare system. We can take care of our sick. In fact, I would hope everybody in here wants to take care of everybody who's sick. It's just altering how we pay for the system and how we do it to the most efficient, lacking coercion and waste, system, and the direct method is much more efficient.
We have time for one more question, so I'm going to ask you relinquish that microphone there. There's one person standing right behind you.
I have to say one more thing, and it'll take 5 seconds. I'm the redneck who shouted Alabama earlier, so. I'm here with the Benjamin Rush Institute, and we have a booth outside, and we spread the word to medical students. So come see us if you think that's something that's worthwhile. Thank you.
Thank you.
Hi, good morning. I'm Jessica McCain. I'm trying to finalize my business plan for a clinic in Fort Pierce, Florida. Anything free market. My husband is an economic kind of guy, so it really turns him off. My parents, on the other hand, turns him on, I mean. My parents, on the other hand, are turned off, and they verbalize their concern that DPC just won't support me in our community, because our average household income is $25,000, our average individual income is $17,000. So what I wanted to get out of this is kind of a spiel. What can I tell patients? If I'm in line at the bank, for example, and I have 1 minute and I can't show them these great presentations and the graphs that show the economic savings, the Medicare patient, 64 years old, they've paid into it. They've waited their whole life just to get that present of Medicare. They can't see spending again for insurance since they've earned the Medicare. What do you tell them to encourage them to seek your type of practice? Thank you.
We have 2 minutes.
I think the poorer and sicker you are, the more you need this model. This system is set up for successful people to use it. If you don't have a car, you don't have car insurance, you don't have gasoline, if you have to take 3 buses and 2 stops and you've got a migraine and you've got to try to get to your doctor before your next shift, that's hard. That's the system, accidentally leaving a lot of people out. But when your doctor will take a phone call, a text message, an email, I have a diabetic patient sending me a picture of her foot ulcer every day so that we can manage it, and she doesn't have to do anything extra. She's getting high amount of care, very straightforward. So you show them the value, and I think that the more value you generate, the more gravity it pulls to it. Medicare is wonderful at what it pays for and awful at anything it decides to not pay for. So wholesale medicine, there's a medicine that's $66 a pill that Medicare won't pay for, that we can get for 19 cents a pill. So we can show the patient that value in 2 or 3 pills. They don't lose anything by joining with direct care and using it alongside of their Medicare, but there's a lot of things Medicare leaves out and a bunch of cracks in the system. So
one of the things I would encourage you to do, I can't see the the last questioner, but tomorrow's sessions, part of that is going to be learning sort of an elevator pitch. I think that's really going to be an important thing, and so we'll definitely work tomorrow on the marketing and how to make that sale quickly. So look at the schedule for tomorrow, but you'll definitely see that session in there about marketing yourself and how to make that quick pitch. All right, a little bit of housekeeping here. Phil Eskew took the red eye in from Wyoming, so he was running 3 hours late, but I have word that Elvis is in the building. So so we're going to go ahead and take a 15-minute break. We want to start back sharply at 10:30. Let's try to keep this on schedule. Give our panel a warm round of applause. Thank you so much.